And we're live.
Good morning, everyone. This is Health and Welfare on Wednesday, March 12th. And I'm the Vice Chair, Senator Bueller, for starting off the meeting today. We have a forum of folks here and we have a packed agenda. So we are going to get going right off. I would like to welcome Dr. Rick Page, Dean of the Larner College of Medicine, to our committee. You have the floor.
Thank you very much. Vice Chair Gulick and members of the Senate Health and Welfare Committee, it's really a privilege and an honor to get to visit with you. I think in my first year in 2019, I had the opportunity to visit this committee and very much appreciate the invitation. By way of introduction, I grew up in Storrs, Connecticut, moved around the country in my career, and I'm a cardiac electrophysiologist, which means I'm a heart rhythm specialist. I still see patients on Tuesday mornings in clinic. And since October of 2018, I've served as the Dean of the Larner College of Medicine at UVM. I came to the college, to UVM and our great state of Vermont, to make a difference. And soon after I arrived, having had the experience that I had, I recognized that Vermont needs a National Cancer Institute, or NCI designated cancer center. Now, there was an NCI designated cancer center until 2008, and related to, frankly, lack of support by the university, college, hospital, and state, that was lost. There had been an aspiration to get that back, and it's been recognized ever since it was lost, what a loss that was. Now, in my career, I've had the opportunity to serve on the faculties at Duke, UT Southwestern, University of Washington, and most recently, University of Wisconsin, all associated with NCI designated cancer centers. When I arrived, I determined to invest a significant amount of what I had available in terms of resources toward our receiving NCI designation for our cancer center here in the state of Vermont. So to make that happen, I worked with Steve Leffler, John Brumstead at UVM Health Network, then Provost Patty Prelog, as we decided that we would move forward. And I also had the opportunity early on to speak to this committee and others in the State House. We installed interim leadership and conducted a national search. And we're thrilled to bring Randy Holcomb from Hawaii. He's an oncologist and had been director of their NCI designated cancer center in Hawaii. Since his arrival, the progress to what our vision we established in 2018, 2019 has been nothing short of spectacular. Even the External Advisory Board, which recently visited, commented on, quote, the tremendous progress in their annual review just a few months ago. They were optimistic, as are we, for a successful submission for the core grant to the National Cancer Institute in the fall of 2026. And that's been the vision for a number of years now. Now, one factor is still missing in terms of having a credible submission to NCI to grant us NCI designation, and that is state support. We need to demonstrate that our state is committed to this, to be taken seriously in terms of receiving designation. I should note that other states invest significantly in numbers that we do not imagine Vermont could or would be able to invest. But it's recognized as being good business. It's smart for the state as well as for the patients. An NCI designated cancer center is a driver of the economy, supporting good jobs and bringing substantial economic benefit to the state in which they're housed. Now, today you're going to hear in just a moment from Dr. Holcomb some of the specifics of the amazing progress he's made in terms of education, research, community outreach, and most importantly, clinical care. We can get there. We can have a credible submission just coming up a year from this fall if we have state support. I emphasize that the cancer center designation will have a positive impact for every individual patient throughout our state who may be at risk of or have cancer or be treated for cancer. This will make a difference for everyone in the state. I'd also mention that this relates significantly to primary care. And I would posit to you that this will have a positive effect on every primary care doctor in all 14 counties. To have this resource, to have this direct line to the cancer center, as well as support of all of its missions of education, research, clinical care, and community service, that's going to increase the job satisfaction and the ability for our doctors in rural counties to provide the best possible care for their patients. To have that as you need it connection with the cancer center when their patients, when they need information, when the patients need care, and also getting those patients back to them and having them feel like if they're giving the best possible care. I believe that will improve our ability to retain and recruit our primary care workforce. I really appreciate the opportunity to visit with you. I'm going to pass things over to Dr. Randy Holcomb, and then we can both take questions if you like after he speaks.
Before you two switch, I was remiss in not introducing ourselves to you. So we'll go around the room very quickly, but thank you very much for that. That was enlightening. And you say fall of 20, are we talking fall of 26?
Right, for the submission.
Okay.
So at that time, what we really need to demonstrate, the NCI is going to review us just as it reviews other states and other cancer centers that are put forward. Many states have more than one cancer center. Some states have not. If they see that a promise has been made for money in the year of submission, they are perhaps more skeptical about the state commitment. Okay. You all may recall that 2 years ago, Dr. Holcomb and I spoke and didn't have any asks. And last year we were requesting $5 million over a year over 5 years. Recognizing the tight times, the request is for $1 million and a commitment for annual support for that. If that is in place this year, then we have at least a year of that kind of commitment demonstrated, where just a year from this coming fall, we submit for what we really believe can be a successful submission of a core grant to acknowledge the excellence we have and also get that support on which we can build for the other missions that I mentioned.
Wonderful. Thank you. So I already introduced myself. I'm Senator Martine LaRock-Ulick. I live in Burlington and represent Chittenden Central.
I'm Ann Cummings. I'm here in Montpelier and represent the Washington District.
Nice to see.
Larry Hartz, Orange County.
Sam Douglas from Orleans County.
Nice to meet you. And I can't keep track. I've visited before. I know Chair Lyons has been here every time I think I have, and some of the rest of you as well. I'm genuinely grateful that you've taken the time to allow us to visit with you.
Thank you for the great testimony.
Thank you.
Good morning.
Good morning. Thank you very much for the opportunity to come and speak with you here today. I know you have electronic packets. I have paper packets. If you guys like paper, I'm happy to pass these around as well. And I have an extra one for Kiki up there.
Thank you so much.
So that was a very nice introduction. It's always difficult to follow Dean Page because he says nice things. I'll give you just a tiny snippet of sort of my history and why I'm here in Vermont. And then I want to give a little summary of what's going on in the Cancer Center, and then a little more detail about what I think we can do with some state support that's really going to benefit people for all across the state. So I'm a medical oncologist. I see patients at the medical center in Burlington. I'm a GI oncologist, so I just see patients with GI malignancies. I trained in Boston. I've been to a few different spots, academic spots, Louisiana State University, University of California, Irvine, Mount Sinai in New York, and then most recently at the University of Hawaii Cancer Center, where I was director. And I came here to Vermont because I saw what the potential was to build a center here. and really felt the deep commitment from Dean Page and university and Health Network leadership because I knew it would take some investment to build the center. Our goal has been to attain NCI designation. I don't actually see that as the goal so much as really an affirmation that we've built the center to a sufficient degree that we can attain that designation, and that will demonstrate that we have excellence in all of the key areas that are important for a cancer center, and those include research, education, clinical care, and community outreach and engagement. And those are indeed our four pillars. And I thought I would just give you a summary of some of the things that have been going on in each of those pillars over the last year. So on the research side of things, one of the things you may or may not know is that Vermont has the second highest incidence of melanoma in the country. It's a major concern for us. We have basic research that is ongoing at the Cancer Center to try to understand why melanoma develops and what the key factors are that may be influencing the high rate here in Vermont. And we also have a major campaign in association with the Department of Health and also in association with Dartmouth Cancer Center, which is focused on sun safety. And you may have seen our sunscreen dispensers across the state, lots of different parks to really try to protect people from the sun. Also on the research side, we found that the response to treatment for people with cancer is significantly influenced by the gut microbiome. We have a new researcher who we've just recruited this past year, who specifically studies the gut microbiome and how that can be modulated so that patients respond, especially to the new immunotherapy medications that have really made such a difference for our patients. Good morning, Chair. Glad to see you.
I had another meeting that kept me, and it's a pleasure to have you here. So thank you.
Thank you.
You're in good hands with Senator Rock.
We've been rolling along. Yes. And then another new recruit that we have is focused on developing a non-pathogenic bacteria that can recognize proteins that are secreted by lung cancer cells. And the reason for that is that we have a high mortality from lung cancer. This affects our rural communities significantly. It's very difficult to get lung cancer screening because you need a low-dose CT scan that's not always available everywhere across the state. And this researcher is actually trying to develop a new mechanism for lung cancer screening that will be particularly applicable for our rural residents here in Brooklyn. On the education side, many of you know about our program, which we call Careers in Cancer, which occurs in Chittenden County. We invite high school students from across the county to come to the Cancer Center, spend a day in the laboratories, hear some lectures, really to get them excited about science and STEM careers. You'll see on the sheet here that I provided for what we hope to do this next year is that we plan to take that program on the road to our rural counties and rural high schools across the state. We've already invested a significant amount of money in what we call our biomobile outreach van. And we have a fluorescent microscope in it and gel electrophoresis and some really cool things that I think high school students are going to enjoy and that they don't have access to in all of our high schools across the state. On the community outreach and engagement, two big successes, I think, over the past year. We partnered with the Vermont Language Project to translate breast cancer screening information and specifically targeting the Nepali women in our state. It's a growing population, and they really had no knowledge about breast cancer screening or cancer screening at all. And so we were able to screen 35 women this past year who otherwise would never have undergone mammographic screening. And we've also had a big campaign to try to increase our lung cancer screening. And over the last 3 years, we've increased lung cancer screening by 35% here in the state of Vermont. And we have aspirations to do even better. And then finally, on the clinical side of things, as I mentioned, immunotherapy really has improved survival for our patients. We have many more survivors in the state, which is great. We have exercise and supportive care programs for patients both while they're on active therapy and after therapy during the survivorship phase, because we know that this actually improves not only quality of life, but actually improves survival. So just as a brief summary about what we'd really like to do over this next year, I've already mentioned our outreach education van. 1 minute, I will go quickly. And that's our mobile van on wheels. We have gotten approval from the American College of Graduate Medical Education to expand the fellowship program. We would like to take the hematology oncology fellows and rotate them through rural sites across the state so that we can teach them about how to provide oncology care in rural settings. We know that most individuals stay wherever they train, and we would like to train them in rural settings so that we can increase our workforce, because our oncology workforce is aging in the state of Vermont. We also want to partner with primary care providers who are often reluctant to take care of cancer patients, especially when they're on active treatment, and provide the backup for them so that patients can get their care for diabetes, hypertension, and other things that should be handled by their primary care provider close to home without having to travel to an oncology treatment site. And then we have already initiated a nutritional consultative support for patients with cancer. We're doing that with Bennington at the moment. They don't have any dietitian to support their outpatient oncology patients, and that's a circumstance that is repeated across the state at most cancer treatment locations. And so we feel that this nutritional intervention will also improve quality of life and improve outcomes for patients.
Dr. Holcomb, that was amazing. Thank you. We are going to dig into this incredible material that you shared with us, and we so appreciate you being here. I also want to say thank you to Wendy Koenig. I can't help but say it with a German accent. Wendy Koenig on the screen. Thank you. That was great. I, again, really appreciate you being here. I'm going to pass the chairship over to Senator Lyon.
Well, thank you. Good job. Thank you. But thank you for being here, Dr. Page. Thank you for being here. So I know the work that you do is sometimes behind the scenes that people don't understand the extent to which you're supporting cancer patients across the state, and as well as medical students and others. So thank you. Thank you.
Well, thank you for the opportunity to come today. And we're always available, both of us, for any additional questions, of course. And
it's good. Well, we know, and we do have legislation, of course, that affect healthcare, but specifically different types of cancer and cancer screening. And so it will be helpful to have you available to us. Thank you.
I'm happy to be available at any time.
Perfect.
Thank you.
And my thanks as well, Chair Lyons. I was reminiscing before you joined us that it's been 6 years, I think, since the first time I got to visit this room in this State House.
That's right.
And appreciate your support. And you didn't hear my statements, which pale in comparison to Dr. Holcomb's, but as opposed to previous visits, this is the time when we have a window where if we can demonstrate support, we can leverage that investment many times over by really providing credibility for our Cancer Center Support Grant, which is going to go in fall of 2026. We've been aiming at that for years now, and the state support is one key component for us to be taken serious in terms of that.
Thank you.
That's so,
Yeah.
so thank you for allowing us this time.
Thank you.
I'll fill you in on the testimony.
Yeah, no, I can see the Zoom.
Yes, you can.
I get to see the Zoom.
Well,
Great.
Thank you.
Thank you.
Oh,
Bye now.
good. Thank you very much. We've got folks now. We're turning to our committee bill, actually, and trying to pick up some threads in information that we need to understand everything that's going on and to inform our bill process. So we've invited different members of the board. Actually, Owen Foster has suggested members of the board who could speak to sections of the bill, and we appreciate you all being here. So we're going to start with, do you have an order that you wanted? Oh, Diane is here. Thank you.
Good morning,
Madam
Madam
morning.
Chair. If you don't mind, yes, there is an
Okay.
order to it that, this morning between 9 and 10, we're going to do sections 1, 2, 3, and 4.
Okay,
Okay, we have with us, several members to speak to that. Mike, Mark, Dave is here as backup. If we need him in the room, and then we have, Matt with us from finance around many areas, but one in particular that he'll speak to. And we'll, from 9 to 10, and then we'll be back again at 11:15 to do the rest of the bill.
perfect. Okay, so the sections again that you folks are talking about are Diane.
Section 1,
1,
2, 3, and 4.
well, 1.
Here we go.
Well, oh, I can do that.
Trying.
So,
Also,
we'll just have you go right into testimony. We're limiting our questions, so we really want to understand your comments. We may offer our discussion will happen later.
Sure. So, thank you for having me here today. My name is Michael Barber, General Counsel for the Green Mountain Care Board. I'll be trying to tackle sections 1 and 2. Try to keep it at a high level, but tie comments to specific language.
And make sure, I haven't checked yet. Do we have all your testimony online? And we would like that. We could get it because we aren't going to memorize, and it's easier it's easier to listen than take notes.
Sure.
Bad students.
Sure. I will be happy to get that to you.
Good.
So sections 1 and 2 deal with reference-based pricing and hospital global budgets. And we are generally supportive of these provisions in that direction. We're eager to begin regulating prices more directly, I think. But we do think that there will need to be some changes to the specific language as this moves forward. So I'll try to just speak to that generally.
So when you say when it moves forward, we're moving this bill out of here on Friday. So any specific suggestions you have would be helpful, and sending those in to Kiki, and we'll get them to Jen Carvey, lawyer to lawyer. That doesn't mean we're going to accept all your recommendations, but we'll at least have them in the right place.
So the first comment deals with the language on page 2, line 13. But it specifies that the Green Mountain Care Board will begin implementing rate setting with reference-based pricing in 2025. Unfortunately, 2025 is not possible. We would prefer if the language said something to the effect of as soon as practical, because the time frame for this is a bit uncertain at this point. We would also like the ability to select one or more hospitals to begin this with, to pilot this with. And I think that's the appropriate place for that language, if you're inclined to accept that. The next comment is on page 3, lines 2 through 9. This adds to the Green Mountain Care Board's hospital budget duties by specifying that the board will establish standards for global budgets to reflect the implementation of reference-based pricing and the total cost of care targets in the new healthcare delivery plan. And also that beginning in fiscal year 2028, the board will establish global hospital budgets for not fewer than 5 Vermont hospitals that are not critical access hospitals, and by FY 2030 for all Vermont hospitals. So just want to note here that the AHEAD model agreement that we have with the federal government has annual targets for the percentage of Medicare fee-for-service net patient revenue has to be in a global budget, Medicare global budget, over the life of the agreement. And so we might want to consider aligning any phased in implementation of global budgets in this bill with the targets to the AHEAD model.
We like the word align here, so you might have a winner there.
Moving on to section 2. So page 5, line 13. through page 6, line 3. Says essentially that the board will establish reference-based prices that represent the amounts that payers in Vermont shall pay to healthcare professionals for services delivered to Vermont residents, and it requires the board to consult with payers, including health insurers, which is a defined term, and AHS, on ways to approach reference-based pricing to achieve all payer alignment. So, we think that the types of payers subject to reference-based pricing, could be defined and probably limited to commercial payers. And if the intent is to affect the amount that self-funded employers pay, we'll want to think about how best to frame that for ERISA purposes and whether we can frame it as a regulation of payer payments, or we should frame it instead as a regulation of provider charges. The types of services that are subject to reference-based pricing could also be defined. If you want to specify that, or if you want to leave that to the board to decide, as a question for you guys, obviously. But Oregon has some statutory reference-based pricing language in their statutes that could be a place to look at that model. Yes. Okay.
Do you have that? And can you include a link to that?
I can include.
Okay, good.
Moving on to page 6, lines 12 through 15. Says essentially that the board will begin implementing reference-based pricing by establishing amounts that health insurers in the state pay to Vermont hospitals during fiscal year 26 for services delivered to individuals covered by the health insurers' health insurance plans. So again, fiscal year 26 is not feasible. We prefer that as soon as practical language. And I also just want to note here that I read this language as saying that we're going to start reference-based pricing with fully insured health insurance plans. So that language around the health insurers' health insurance plans is I think talking about fully insured plans. So if that is not your intent, I would recommend changing that. Page 6, lines 16 through 21. We have concerns with the breadth of this. I'll leave it at that. I think Owen could probably, Chair Foster could probably speak to that better than I could, and I will make sure to cover that in a written testimony I provide.
Good.
All right.
Still being 11.
And then this is the last one I have. So for page 7, lines 1 through 2, specifies that the board may enter into contracts as needed for the initial implementation of reference-based pricing. I appreciate that language. I think it's probably not necessary. We have the authority to contract as needed to fulfill our duties, and wouldn't want to suggest that we don't have that authority elsewhere, or the authority to contract to the continued kind of maintenance of that reference-based pricing programs.
One of the reason it's in here, obviously, is that to start a reference-based pricing, you need to have experts, and you're going to be hiring. So we do have appropriations at the end of the bill that allow for hiring new positions to help with that. At the same time, we think it's important to justify money that's in the bill, that will be in the bill. We can move this later to the appropriation section, but so that's why it's there.
Sure.
That's just it. That's why it's there. And we can consider the need for it.
Thank you.
Thank you.
Dave, did you have anything you wanted to add?
I mean, I don't have any, I think, specific comment beyond that about the details of it. I do think, generally speaking, and I'm not, there we go. Director Dave Merman from the Green Mountain Care Board. On my iPad. So my understanding with this, with ERISA laws, is that we really want to regulate the hospital side as opposed to the payer side. And I would defer to the attorneys on this, but I think that we should be careful in the language we use. And we may need to do a little digging into charges or allowed amounts or exactly what the right term should be used on the hospital side. I do think Oregon does have some pretty good template language, although they do it differently because they just are doing market-based pricing for the state employees' health plans. And I guess the one other thing that I wrote myself a note on that I think we should circle back on is what to do about, and Oregon again has really good template language for this, we can bring this to you, is what to do about services that are not common under Medicare. So pediatric services or obstetric services that we want to use a different reference. So we may need to either be less specific as referencing to Medicare or be more expansive into sort of other potential
And others, right,
ranges.
services not covered by Medicare.
Yeah.
Yeah.
But overall, I think the intent of this and the direction of this is something that I'm very supportive of. It's you know, it's a lot of additional things that the board is going to be doing. So there's a lot of work here, and I think between this and kind of what we're going to talk about later. So I do think we need to be mindful of how much we can achieve.
Oh, we're aware of that.
Yeah.
Yeah, we were very aware of that, and that's why we put in some resources.
Great.
Yeah, we get it.
Great.
Thank you.
All right. Thanks.
Good. Thank you.
So
Okay,
thanks.
all right.
Hi, good morning, senators. We haven't met yet. My name is Mark Hinkster. I'm an attorney for the Care Board. We have not met because I'm still in my first year here. I was doing legal aid work before this and was in the healthcare advocate's office ages ago now. So I've been watching you for a while, but long time listener, first time caller. So I'm going to talk about sections 3 and 4. These are the sections about hospital budget regulation. I want you to know, highest possible level, we really support these sections. These work really well. I'm going to get into some kind of nuancy work. I'm going to describe something, and also just say, you don't have testimony for me. You will have it very, very soon. You don't have testimony for me because I was doing this at finishing this at 4:30 before my kids got up. Some of what I describe are up to you, are things that you might want to tackle between now and crossover. Other things, if you support them, we're happy to work with Jen Harvey to get those projects done.
Well, so here's the thing. We want to get a bill out of here that we feel good about. And if there are things that are left that are unsettled, that we won't feel good about that. So any help, any support, send ASAP, and we will work with our attorney to understand what it is that you're sharing with us and see how far we are.
So I'll give you for written testimony, I'll give you the high level. These are the two things that we think
And I'll tell you why. So the reason we passed the bill out on February 28th was to allow for a whole week for this kind of decision-making to go on. So now we are hearing it for the first time, but I am hoping that you have solidified your comments. Good.
Yeah, absolutely. No, comments are solid. And what I want to do is share a couple of things. And then when I give you written comment, what you'll get are, these are the things that we think are the most important. Good. Okay. So starting with section 3, which is the hospital duty section. I want to speak just broadly to what this section is in comparison to section 4. So section 3 references 18 VSA 9454, and this section is about the duties that hospitals have in filing documents with the board. That's 9454A, and then 9456, which is section 4, is about the board's hospital budget review process. So that section has all of the language about what the board reviews when it does hospital budget review. And kind of interestingly, that section also includes information about things that hospitals need to file that are different from what's in 9454A. So I share that because I think I heard a comment from Vaz yesterday about opposing some language in 9454A at page 7, line 14. and I think down the line 20, I believe is Vaz's comment. And I just wanted to share that to the extent that there are overlaps, Vaz's position, as I understood it, was that there are overlaps here with what's in 9456. To the extent that there are overlaps, we would be happy to work with Ledge Council to provide some ideas for getting all of these into one place, if that's useful, so that the items that the hospitals file are right in line with the things that are reviewed, and there's not any potential ambiguity about those two things. That's an item that we probably couldn't do like today, but we'd be happy to work soon on that. So with that in mind, starting with line 14, this is the requirement that hospitals file information about the number of employees whose duties are primarily administrative and the number of employees whose duties involve delivering healthcare services. This is something that we are already doing. We already have definitions for these terms in our uniform reporting manual. I think having this in statute is great. It ensures that the board keeps doing it. So yes, this is good. The second one is at line 18. So information regarding base salaries and total compensation for the hospital's executive and clinical leadership and for its employees. Again, yes, and this will go into some comments I have on hospital executive pay in section 4. So both of those look good to us. So moving on to page 8, there are 2 references to a uniform system of accounts. I'll just flag the first one is on line 1 of page 8. So we're still in section 3. And this is this requirement.
Line 1 through 8. Okay, got it.
Yeah. So all hospitals shall use a uniform system of accounts identified. And then when we move into section 4, there's mirrored language. Starting at line 9, the board shall require hospitals to use a uniform system of accounts. And what I'd like to do is give Matt Sutter from finance a minute to talk about that language because he's going to be the best at doing that. So I'm going to vacate the chair for a minute.
Oh, good.
Thank you. For the record, I'm Matt Sutter, Deputy Director of our Health System Finance team at the board. I just wanted to quickly talk about, my understanding is the intent of the committee is to give us better understanding or analyses of or ability to analyze expenses at the hospital. Currently, maybe what I need to do is describe it very quickly and how our expense structure, account structure is in an adaptive our financial system. Right now, hospitals report consistently on salaries and benefits, provider tax, depreciation, and interest, and a bucket called other operating expenses. Now that other operating expenses is almost a third, probably a little bit more than a third of their total expenses. And in that are things like med surg supplies, pharmaceuticals, just massive expenses for the hospitals that we don't get reported on in a consistent manner. Now, hospitals do report on those kind of more child accounts that roll up to those other operating expenses. Each of them do report on them differently, and we do have some insight at a like individual hospital level how these other operating expenses are changing, but we don't have them in a like holistic system-wide. And what we've heard from hospitals in the past is that their charts of account don't allow for these sorts of consistent analyses. And I totally, in our account system right now, I could go in and change it with adaptive. I could change it to whatever I want. I could change it. We can change the reporting manual, and ask hospitals report in a consistent manner. That doesn't mean they necessarily can. So what would be very helpful for us from a regulatory perspective is to figure out that like lowest level of expenses that we can get at from the hospitals consistently, so that we can better answer those types of questions. Because it's a basic question people might ask: what's going on with med surg expenses system wide? I can't give you an answer on the system. I can tell you for some hospitals that report on that, but I can't tell you, hospital, Chris Cottage has seen X percent and the system has seen Y percent. We just don't have a full set of data to be able to do that. And so rather than requiring hospitals all have the same chart of accounts, what would be helpful is a mapping of their existing chart of accounts to what we have in adaptive, and perhaps a recommendation for how we could improve the chart in adaptive. I can just say,
and we've heard that. We actually heard that adaptive is a program that you've been working with hospitals for financial purposes.
Yeah.
So something in here that references that work is what you're saying.
Yeah, and we can submit a recommendation to that effect. But yeah, that's I think our ask.
Okay, and then I've also heard that you're interested in having hospitals report specific type of information. So is it helpful to say anything about that the hospitals will respond or that you'll establish guidelines for the type of financial information that's being reported? For that.
I believe we already have necessary authority for
Oh.
consistent reporting there, but we can definitely double check it and follow up.
Okay. This is helpful, and we will get something from you.
Absolutely. Yeah.
Terrific.
Yeah.
Excellent. Thank you.
Also. Appreciate you letting us do a little hot seat there. Mark Hainsler, Fairboard. So what I'm gonna, we're now in section 4. This is the section that's about the board's budget review process. So first, you're going to hear about the part of this section of the statute that concerns all of the elements of a hospital's budget that the board reviews annually when it's doing budget review. We do that for all 14 community hospitals and for the retreat. This second section you'll hear about is the section about what the board needs to establish in each hospital budget. So what does each hospital budget need to contain? And then there's some elements here toward the end that are about, I'd say like thematically, what does the board do if a hospital takes action that seems potentially out of line with the statewide healthcare delivery plan? So I'll go through a few pieces of the review. To start, at line 14 on page 8, the concept that we consider.
On which page?
So page 8
Oh, I'm sorry.
on line 14.
Yeah.
These are items that the board reviews annually for each hospital when it's looking at budgets, considering the statewide healthcare delivery plan. Of course, yes, we support that. That makes a lot of sense.
Once it's established.
Once it's established, of course, yeah. Moving on to page 9 on line 4. For a hospital, this is item 6, for a hospital that operates within a hospital network, review the hospital network's financial operations as they relate to the budget of the individual hospital. I think this makes sense. You're going to hear Chair Foster later today talk about section 5, which is the section about review of network level operations. I just want to take a step back and say, I also think this makes a lot of sense when you look at the healthcare principles at 9371. So the way that we're designed at the board is we start with these healthcare principles that are at the very top of our chapter in 18 VSA. Then we have all of these board duties, the things that we're required to regulate and have authority over. Our duties all connect back to our regulation in support of and in continuation of those healthcare principles. So everything we're doing is based on those healthcare principles. And when I look at item 6, what I see a few really important connections here to those healthcare principles. And one of those is 9371-6, which says that healthcare systems must be transparent, efficient, and accountable. And I think right now, without the ability to look at and fully incorporate into our budget process network level decision-making and budgeting, that transparency, efficiency, accountability is the thing that we think this really hits. And I think that's really good and is really in line with what the principles for healthcare reform are trying to do. So that's our position on 6. 7, which is line 7 on page 9, is this idea of developing incentives for hospitals to support community-based providers. There's a little bit more, there's a lot more language in there, but that's the general gist. Yes, we want to see hospitals doing this. My only suggestion here would be to change the word develop to the word review. So the idea that the board is reviewing hospital incentives, and that's just in line with the concept, this part of this section is about reviewing things that hospitals are presenting to the board as part of their budget. So that's all I have on page 9. I'm going to move on to page 10, and there's actually nothing on page 10. So we can just keep on moving, just moving. So page 11. I want to take a minute on line 1, which is item 16. We're still in the items that the board is reviewing. We're almost done with those. This item starts with old language is already in statute that says the board will consider the salaries of hospital executive and clinical leadership and the hospital salary spread, including a comparison of median salaries And then the new language is a comparison of the base salaries and total compensation for the hospital's executive and clinic leadership with those of the lowest paid employees who deliver healthcare services. So I'm going to break this one into two parts. We support all of this. I just want you to understand where our support is coming from. So for the first part, this section is really doing the work of allowing us to look at administrative expenses. The only item that we would propose considering is including consideration of salaries for hospital and hospital network executive and clinical leadership, and also including a call out to variable payments and incentive plans. And the thinking there is that I think something we're learning is that the results that executive leadership are being incentivized toward might not always align with the principles for healthcare reform. And maybe in other circumstances and other points in time, that wouldn't really be an issue. But given where we're at right now, any alignments we can all be paddling in the same direction just seems really, really valuable. So that's the thinking for, giving the board authority to review and really treat as a regulatory function what those incentive plans and variable payments are, and if they're attached to what our goals are. As for the new language here, yes, we support this. I do think I heard opposition from Voz the other day on this item, explaining that this would add a reporting burden for hospitals. I'd be happy to hear more about that. My only observation is that we already require this in our uniform reporting manual and in our guidance every year, and hospitals do it, and we define the terms. So we have all of this defined. It's all in a document. I can show you the document. It's all there. I'll link to that when you get my written comment. So on to page 11, line 8, we're at the last item for review. Thank you for bearing with me on all of these. This is a requirement that the board consider the number of employees whose duties are primarily administrative, as defined by the board, compared to the number of employees who are primarily involved in delivering healthcare services. We already do that. Again, that's in our uniform reporting manual and our guidance. There's this language here about national average staffing ratios, which is the second clause of that sentence. It's everything after that comma after hospital patients. We would propose either limiting or removing that section only because the board already has authority and a practice of establishing metrics and peer groups by which to compare hospitals. And our finance and analytic team are very good at that and have great documents on that. And those documents are posted online, and they can work with kind of the right way to do peer grouping. Okay, so that's everything for what the board is reviewing. And now I'm going to turn to this language that is starting at line 14, so on page 11, which is what hospital budgets need to be established with. 10 for maybe line 10 for you.
Statewide healthcare delivery plan.
Statewide healthcare delivery plan.
Right, page 11.
Yeah, so our lines are slightly
Maybe slightly different.
We-
Okay, I'll give sections.
We got it. We got the
Yeah.
underlining. Yeah, we're good.
Yes to establishing budgets that consider the statewide healthcare delivery plan. Only proposal from us is to change the word to be consistent with to consider. And my thinking there is that the statewide healthcare delivery plan has it identifies a total cost of care target. And there's also language, I think, in the current draft about that plan identifying an appropriate allocation of healthcare resources. No, I have no problem with that language. I just am a little bit worried about that plan getting formulated, there being some really nitty-gritty things in there, and then maybe things really changing very quickly with the landscape and the board needing to establish a budget that might consider that plan but not be consistent with it.
Right, we understand that the plan does have a evolving feature to it every 3 years, so maybe say something like to the extent practicable, or, as a chance.
Absolutely, yeah. So C2 reflect reference-based prices, yes. And then I'm going to go to page 12. And The only other item I wanted to touch on for page 12 is just a proposal that you consider including, this was back to my earlier comment, consider including a requirement that when the board establishes a budget, it includes the budget includes meaningful variable payments and incentive plans for hospital executives or for network executives to the extent that hospitals part of the network. Okay. You have language at D1B, which is language about the global budget. You can just refer back to comments. This is language that mirrors what was in section 1. So same concept of this language works if it just aligned with what the ahead performance year targets are. That would make sense.
Yeah, as long as we put that up front as the umbrella, then our whole set.
Yeah. Okay. So we are on page 13, and I'm going to talk with you. This is my last thing. So again, thank you for the time on this. This is E1, 2, and 3, and I just want to share what I think this section is doing to make sure I'm tracking it and that we're on the same page. This section to me really seems to get at what do we do when hospitals take actions by need or otherwise that might not align with, or that we might worry wouldn't align with the statewide healthcare delivery plans. And I think this language talked about as something like a reverse CON, but I just wanted to give some thinking high level about what seems to make sense from our perspective. And at the core, I do want to say that we support this and really like this. So starting with E1, this says that the board shall establish outcome measurements that ensure that hospital costs are appropriate, that quality and access are maintained or improved, and that hospitals shall implement their budget orders in a manner that's consistent with the healthcare delivery plan. My only item here is that an easy yes to hospitals implementing their budget orders in a manner consistent with the delivery plan. Going back to what I said earlier, we have authority to set peer groups and metrics, and we do that each year as part of guidance. So if this established outcome measurements language were removed, that is a function that we already have authority to do and are doing. And just so you know what that looks like, what we do for hospital budget process is we issue guidance with a document that is like an inventory of all the metrics that the analytic team is using to compare hospitals. And we say, okay, these are all of the peers that we're going to compare this hospital to. And then we say, these are all the different kinds of metrics we're going to look at when you're comparing to your peers. And we have a chart, and everything is, for each metric, there's a peer group, and there's a definition, and there's a description of what the metric is measuring, and the board is using all. So that's what the process is that we have right now. So moving on to E2. This is the language about hospitals reporting to the board and others. So this is that if a hospital proposes to reduce or eliminate a service to comply with its budget, it provides notice to the board, to AHS, to the HCA, and to the affected members of the General Assembly, not less than 90 days before the proposed reduction. And my only item here is a proposal that the notice described how the change in the change the hospital is going to make will align with the healthcare delivery plan. So if the hospital is giving us notice that it's going to make a change, it would be helpful to have the hospital explain, we looked at the healthcare delivery plan. This is how we think this supports that plan. We think it's going to reduce premiums in this way. We think it's not going to affect care in this way. That way we start on a common basis of understanding of here's how the hospital understands what it's doing. And then there's this language about the board shall evaluate the proposed reduction or elimination with the hospital transformation efforts, or for consistency with hospital transformation efforts. I would propose changing the shall to a may, and my only thinking there is I don't really know how much is going to be coming at us, and having some ability to prioritize what fires we're trying to put out might help.
That makes sense.
Okay.
Yeah, that's
Okay. If we could do all of them, like obviously. just maybe realistic. Okay, so moving to, I'm just make sure I have everything there. So moving to this, this third item, which is the board, collaborating with VFR to monitor, any authorized decrease in services to ensure that they result in a decrease in health insurance premiums or investments that support primary care. We would recommend removing this. I think it would be analytically very difficult to draw a straight line between reduction of a hospital service and reduction in premiums, just because there are a lot of items. Yeah, please. Joanne.
We do want to see an effect.
Okay.
Okay, so then, yeah, so the question would be what effect? And perhaps it's inserting something as such as, an effect such as, and if there, and then, there needs to be some measurable something. And I have talked with Chair Foster and Secretary Samuelson about the language, Chair Foster in particular. So let's not get firm into that one yet. Okay,
All right, because
let's see an effect.
yeah, there's an awful lot that goes into premium, and if you're closing a dialysis center, but those people are receiving dialysis, I hope, somewhere else, that's not going to have a,
That won't be the premium
that
effect,
won't have a premium
right?
effect.
But there could be other benefits that come from that. So
Staff is
yeah, and I've got some such as I've been trying to think about, and others have. So we'll.
That makes sense to me. That makes sense to me. That's all I have for comment. Again, thank you for bearing with me on a lot of material.
thank you for bearing with us.
You think you no, we're excited about what we're doing, and we appreciate the work that you're doing on this, the board as a whole. I mean, really, thank you very much for taking the time. We understand that the board is a regulatory entity, and it's not usual for the board to get fully involved in policy like this. We get that, and I'm saying this to you, but collectively to the board as a whole, how much we appreciate the time that you're taking to work this through. Reason is there's a huge crisis right now, and the crisis is very much evident with hospitals, and we know that. And we know that the crisis is very much evidenced by our commercial insurers problems. But we're trying to sort out how we can have an effect. Such as, we'll do the work that we can, but thank you. Is there anything else that, anything else before I go to Diane is to, make sure that you get your written testimony in with alacrity. So we really need that, in here, and alacrity is a word that we're going to pin up on the wall. It's so important to us. And again, thank you. I know it takes time from your day. I know you have a lot of work going on across the street. And when we take our field trip over to see you, we'll see all that work. So thank you. Diane.
Thank you, Madam Chair and Committee. For the record, Diane Lampert, Green Mountain Care Board, and we appreciate this time here. We'll be back at 11:15. But I also wanted to say that today, typically on Wednesdays, is also the board meetings are in the afternoon. And it may be, I don't know if it's an interest, you have your plate is full, but this afternoon's board meeting will include the guidance, the hospital guidance review map, and the actuals on 24 will be coming up. Also, I wanted to state so that you didn't think that in isolation, as much as that we work on many levels, that we are in communication with AHS and others constantly. And we knew that we had to be here this morning. They're here tomorrow morning, but in between, we're still talking and we're still refining and still working together so that we have, and you have, a product for Friday that meets your satisfaction.
Yeah, no, thank you. I appreciate that. And the collaborative process is one that we've been promoting in here since we started this. It started with the Health Reform Oversight Committee, getting us all together. So we're going to some of us have been working on longer, but thank you.
You're welcome. We're gonna head upstairs to. And we'll be
Okay.
back at 11:15.
Some of these guys are in kindergarten.
I know, this is the problem, right? So we are going to take a break. Our brains have been